Good morning, everybody, and welcome to the Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce our speaker, Dr. James McKenzie. Dr. McKenzie is a fellowship-trained orthopedic spine surgeon. He's trained in the management of cervical, thoracic, and lumbar spine degenerative, deformity, traumatic, and pathologic disease. Dr. McKenzie is a graduate of Sidney Kimmel Medical College at Thomas Jefferson University Hospital in Philadelphia, and also did his orthopedic surgery residency at Jefferson. He then completed a one-year fellowship in orthopedic spine surgery at Emory University in Atlanta, Georgia. Dr. McKenzie has staff privileges at the Holy Redeemer Hospital, Temple University Hospital at Jeans Campus, and the MOVE Center in Warminster. Dr. McKenzie is working to establish a comprehensive spine center at Holy Redeemer Hospital in conjunction with the Global Neurosciences Institute. Dr. McKenzie is an active participant in the following medical societies: American Academy for Orthopedic Surgeons, North American Spine Society, Cervical Spine Research Society, and Pennsylvania Orthopedic Society. Dr. McKenzie grew up in Drexel Hill, Delaware County, and lives in Haverford with his wife, Laura, and their two children, Tommy and Margot. And Dr. McKenzie will be speaking today about elective spine surgery.
Thank you very much. Hopefully everyone can hear me and see my screen here. First off, let me say it is a privilege to be here on a very good Friday, and would like to go through a talk here on elective spine surgery. I'd like to thank GNI, especially Adam Sarkar, who I've been working with over the last few months, as we're working to establish great, outstanding spine surgical care at the Holy Redeemer Hospital System and elsewhere. So the name of my talk is Just Make the Pain Go Away, Doc. And, you know, I think it's so much more than that when you're discussing elective spine surgery, but sometimes it's not. And I think what we're going to try to do today is go through some of the details in a more clinical focused session. We won't get terribly granular on the side of all of the specifics of decompression and fusions, as that would bore even myself to tears, who's actually interested in that. Moving on. I do not have any financial disclosures relevant to this talk, but it's important to go through my personal disclosures and limitations. Again, these are my children. We're heading into the Phillies season. We're 3 and 4 right now, but I plan on fully indoctrinating all of my children into Philadelphia sports fandom. I am an orthopod, so there's only so much bandwidth I can provide against all of these much smarter physicians and providers, along with other nursing and other staff here in attendance. And I'm also a millennial, so sometimes I may stop and tweet or look at my phone during the talk, but hopefully I don't distract you. Patients come to my office and I get a bunch of different comments. These happen at the beginning, middle, end of the conversation. Number one is spine surgery doesn't work. You never get better. My grandparents' veterinarian dog walker's assistant got worse with spine surgery, or whatever relationship they decide to go. I never want to have back surgery. Will I be able to walk after the surgery? And most importantly, and probably an actual reasonable question and comment, is, will the pain go away? So does spine surgery work? Is it something that's worth doing? Is it on an elective basis? There are certainly some reasons to do it on a non-elective basis, but does elective spine surgery work? Well, they've looked into it, and perhaps one of the best orthopedic subspecialty research projects in a multi-center randomized clinical trial was called the SPORT trial, Spine Patient Outcomes and Research Trial. This was spearheaded by James Weinstein and was evaluated and calculated through Dartmouth. And it was a multi-center study, went over the course of the better part of a decade, and they're still publishing actually off of it, and we'll go through some of the details of this. It basically focused on 3 different disease processes: a idiopathic disc herniation, spinal stenosis, which is the SPS right here, or dynamic spondylolisthesis. So 3 different, very common degenerative processes, and it's put into a randomized and observational trial. And they evaluated patients that were randomized into a surgical or non-surgical arm, and then observed in which a normal process would occur, in which the patient elected for surgical or non-surgical treatment and followed accordingly. This was done in multiple centers, including two of the places I trained at Rothman and over in Emory down in Atlanta. So there was a lot of positive findings here. So they looked at the degenerative spondylolisthesis and at 4-year results for lumbar spinal stenosis. They also had an idiopathic disc herniation one as well. And they found that the spinal stenosis showed substantially greater improvement in pain and function if they were performed surgically, if they had a decompression and fusion. Similarly, with simple decompression alone, there was substantially greater improvement in pain and function through 4 years. And so that looked great. So does spine surgery work? Well, you got to think to yourself that it's not just that time frame. You know, most patients, you hope, are those that are operated on are living well past that time frame. So you probably should look again. And they're a little less positive. And I think it shows here that there were some diminishing benefits of surgery in the as treated analysis. And it actually includes a lot of loss to follow-up. So it's a little difficult to fully parse it, but I always get nervous when I see a large multi-center clinical research trial have half the amount of authors on it. I find that that often means that they're kind of hedging. Similarly, in the disc herniation, it really says that carefully selected patients who underwent surgery for the herniation achieve greater improvement surgically. So I think it's very important. So does spine surgery work? I think it depends. So what we'll talk about today is discussing the problem, going through some physical examination pearls that I've found, understanding the problem, going through the clinical encounter initially and subsequently with the patient, understanding that there are patient factors and biases, both for the patient and the physician, that are important to understand when you're discussing the problem. How do you treat the problem? And did you even solve the problem that you did, or what's coming down the road? So the spine examination is an exhausting one. It should be by the end because of all the challenges and the complexities that are involved in it. But I've actually had one of my mentors break it down to 5 questions, which we'll review some key maneuvers, and then the red flags and overlapping diagnoses as a review for everyone here. This is John Rhee. He's one of my mentors down at Emory University. He was the outgoing CSRS president this past year. And my first time meeting him in clinic, it was virtual like this actually, is that he said there's 5 key questions to figure out any and all spine pathology. Where is the pain, numbness, most comfortable, least comfortable positions, and any latent myelopathy. So where's your pain? The specificity is so critical to understanding exactly what you can and can't do and where it is in the evaluation. The dermatome map is something that you just frequently should review. And I really ask patients, I even will often hand them my pen or something specific and say, trace this out exactly where it goes. And you have to ask it a couple of times often. The patient will kind of just circle their thigh, point to their butt cheek and go down. But you have to be specific because these dermatomes oftentimes are within a very reasonable time frame and area. And I love this picture on the left. This is from an old textbook that I got from one of my mentors at Jefferson. And it shows that there are basically 3 kinds of areas that you have to think about. The area around the disc space, the area where the foramen and the exiting nerve roots coming out, and then the top where there's the pedicle. And in a repetitive fashion, not only in the sagittal plane, but also in the coronal plane, you have to think of where the disc herniation is and whether it's affecting a traversing nerve root or the exiting nerve root. Numbness. Is the DRG involved? That's basically the way I think about it, is that there's going to be a degree of numbness involved that may require, at minimum, a partial medial facetectomy, for which you have to get down into that space and then get into the foramen. And understanding that this may involve a long-term process, that if it's been there for 3 months or greater, 6 months, perhaps this numbness may be affected in a longer term follow-up and may not completely improve. Most comfortable position, if you think there's rest relief, you have to understand about neurogenic claudication and also think about the age of the patient as well. If they're walking and they feel better, and oftentimes in younger patients, it's more of a disc situation. And you see here, the facet joints are so critical in understanding this musculoskeletal process and the dynamic action of the spine and how it is affected by certain pathologies. So I think of the disc and the facet joint as two members of the same issue abutting against the foramen, affecting traversing and exiting nerve roots. The pedicle stays basically the same. And so really what we have to think about is, as that facet joint fails, does that superior articular process start working its way up into the foramen? Does the disc start to herniate backwards? Is it a combination of the two that are causing this problem? And then you can understand that if there is more ligamentum hypertrophy and central stenosis, why a patient would like to flex forward and oftentimes use a shopping cart to walk further distances. But oftentimes when they're lying down and just in an extended position like here on the right, that's not going to be as much of a problem because they're not really stressing that joint. What is the least comfortable position? If it's worse with walking, think claudication. Worse with sitting, it's a disc problem. And again, what we should see here is that the least and most comfortable positions should be opposites of each other. It should make sense. There has to be consistency in the patient's examination, because otherwise we have to think about what else may be causing this problem. Difficulty with hands or walking, it's myelopathy. By far, one of the most important things you can take away from the physical examination is always evaluating for latent myelopathy in the cervical or thoracic spine. If it doesn't add up, start looking up. And think of the 3 Bs, bowel, bladder, balance. And the dexterity and things of that nature can be subtle. And so you have to find different ways of asking that same question, whether it's use of a cell phone or if they do specific. I usually ask about clothing, buttons, zippers are oftentimes a good assessment of dexterity and things of that nature. Make your patient walk. It is so critical that, as annoying and as bothersome and as time consuming as the physical exam can and cannot be, having your patient walk is going to help you understand exactly what they're doing. Every patient that I see, I make sure that the first thing I do is have them get up. Can they get up? And make sure I see how they walk, because you're going to learn so much about their analysis of how they're getting around. How do they position their feet? Is there a foot flappage? Abductor work. Are we worried about hip pathology, knee pathology? Have them walk in a tandem gait. Be mindful of the age of the patient and the relative benefits of this. You don't want to create a hip fracture evaluating for hip pathology in an elderly patient in your office. That's a bit of a faux pas. And toe walking is also important to evaluate S1. Having a patient put down on your hand while they're seated is not a full assessment of gastrocnemius strength and function. Similarly, after they've walked and been tortured that way, I torture them further by having them actually bend laterally, not only flexion and extension in the sagittal plane, but think coronally. I think that's very important, along with rotation, because then you're really stressing those facet joints, which oftentimes are a major part of this process. Is there asymmetric rotation in the neck? Then you can think about C1-2. And those things can be subtle, and the patient may not even recognize it, but they've been doing that the entire time. And then, especially in your elderly patients, can they even stand past neutral? Can they extend past that space? Because they may be so stenotic centrally that they have to just flex forward simply to stand. I think one of the best tests for a disc problem, perhaps the most specific, is the reverse straight leg raise. So for example, if there's a right-sided disc herniation and the patient has right leg pain lifting up the left leg, that shows that there's enough stretch and enough of a mass effect of that disc herniation to cause the pain. And this study is from 1979, when MRIs were being developed and were not mainstream. And that was by far one of the most specific and successful studies to evaluate a herniated disc, when that modality of simply MRI for the patient to have your diagnosis was not readily available. Everybody gets a Hoffman sign. That should be always no matter what the problem is. I don't care if the patient has a stub toe. I'm checking the Hoffman sign before the end of our clinical encounter. It's going to test for latent myelopathy, and if it's positive, I get C-spine films regardless. It is a key screening test, and the patient may have no neck symptoms whatsoever, may not discuss anything with their hands or upper extremities, may just have some subtle low back pain that bothers them at times, and can have cervical stenosis that's moderate or even severe. X-rays should always be weight-bearing, in my opinion. If you want to find out what the functional problem is, have functional pictures of it. Flexion and extension will help with dynamic spondylolisthesis, so you can understand what the problem is by getting pictures that illustrate the problem in action. Obviously, there can be many different reasons for leg pain and discomfort, arm pain and discomfort as well. Compressive neuropathies are very important. Canals is a very quick and simple physical examination that at the cubital and carpal tunnel could be performed for every patient. And then just look at their hands. Muscle atrophy is a real thing, and it can be evaluated as well. Not every patient understands where their numbness is coming from and can accurately describe the numbness well. So test those areas. It's a quick and easy way to take care of it. And then the back hip paradigm is one in which I simply rotate the hip in internal and external rotation. That groin pain very, very often is coming from referred pain from the femoral nerve in and around the hip joint, and may even cause knee pain. So, this may not be an L4 radicular problem. This could simply be hip disease, and then you can decide how to approach it accordingly. And then any of the neural examinations for a central nervous system problem, things as simple as tongue fasciculations or some cranial nerve exam, if something doesn't add up to you, or if there's descriptions of atypical migraines or things of that nature, blurred vision, changes in other auditory or visual sensory input, then I do a quick 2 through 12 exam, shrug my shoulders, and then ask one of the Global Neurosciences Institute much smarter physicians to take care of the problem. And then obviously some red flags. I think the most important thing I worry about is the perineal numbness. Cauda equina, oftentimes, I think the horse is out of the barn if they've had frank incontinence, particularly of bowel. So they typically will have some perineal numbness prior to that. And you have to understand when they're having urinary incontinence, whether this is urge incontinence, in which they simply cannot get to the bathroom in time due to some functional mobility issues, or if they're actually having an overflow incontinence in which the sensation and urge to go urinate is not there. Always check the spinous processes. A step off on a spinous process or discomfort there, you really want to consider whether or not there is instability, particularly in the cervicothoracic or thoracolumbar junction, as this would be the main area of the highest stress riser. And then, of course, any constitutional symptoms or infection risk factors. Think about TB, cancer, and other infections. If I have a patient that's high risk and concerned for osteodiscitis or osteomyelitis leading to an epidural abscess even, I'll get ESR and CRP at that initial evaluation and trend that depending on whether or not they've started an antibiotic treatment, as that's the first line of treatment. So we've gone through all of these physical examination maneuvers. We figured some things out. We're feeling good about everything. We're going to solve this problem and doing great. But what problem does the patient have? What is their chief complaint? I will see x-rays of the lumbar spine that show severe degenerative scoliosis and things that would indicate a T10 to pelvis decompression and fusion. And the patient's really just bothered by slight axial low back pain or the occasional difficulty walking with some balance. So you have to understand the power of observation. So to the left here is Dr. William Osler. And then this is Basil Rathborn on the right, who is one of the original Sherlock Holmes actors. So William Osler is a physician that was in the 19th century in England. He was known very well for his ability to use a holistic approach to the physical examination, and someone that oftentimes at my time at Sidney Kimmel Medical College was cited by our physical examination lecturer. He showed such a distinct care and focus on all of the areas of a patient that he was known to diagnose metabolic disorders by simply smelling the breath of a patient. And so to the right, again, Sherlock Holmes, that character was actually based off of William Osler due to his degree of observation and being able to figure things out simply by looking at details that most often are missed by the average person. Similarly, in a similar vein, Dr. Joseph Meiden was one of my mentors over at Jefferson Hospital, and he would say, do not let anything compromise the situation or physical examination. You work to make sure that you figure things out and understand what the patient's going through and things of that nature. And this part of the clinical encounter is the shortest and perhaps the most important when you're thinking actually of the details of why a patient has come to your office and how you can best help them. There are a number of different things that you can observe simply when you're walking in. What is the patient wearing? What are they not wearing? What can you see? Do they have dirt under their fingers? Are they a mechanic? Are they what are the positions of their hands? What expressions do they have? Do they sit slumped? Are they sitting forward? Are they direct? Do they have 2 reams of WebMD printouts for you to review? Who's with them? Now, it's been a little tough during the pandemic, but at times patients will bring other people. Did they bring their spouse, a significant other? Do they have a friend? Did they bring anybody? And you have to use all 5 senses. When you walk into the room, can you smell the nicotine and tobacco smoke that they just had a cigarette outside? And perhaps one of my favorite things now in 2020, post-pandemic, is what mask are they wearing? It's a new accessory, and perhaps more important than what kind of mask they're wearing is how are they wearing their mask? Do they follow the general guidelines? Is it something that they just put on to humor you and follow your clinic's guidelines, or are they wearing it regularly? And what are the ramifications of knowing or not knowing that? So when you're understanding the problem and discussing it with the patient, there's 2 key concepts that I'm always thinking about as we've completed the physical examination and reviewed the imaging and have an idea of what we think the problem is. What's bothering the patient? A lot of times it's pain, difficulty walking, or inability to sleep. And those are the most miserable patients that you will see in the office. And you know that they're tired, fatigued, and they just simply can't get along doing what they're trying to do. I'm very cautious of a patient that doesn't have one of those 3 problems, either difficulty with pain and getting around, difficulty walking in itself, or difficulty with their time at rest. If they don't have one of those 3 problems, I have to wonder what's bringing them in and why they're having this evaluation. What does the patient want to do if the pain goes away? I think this is one of the most underrated things we have to think about. And perhaps one of the main things I will tell my patient afterwards when discussing the surgery is what they can and can't do during what time frame, and then long-term what they're going to be able to accomplish. Learn the patient's why. Very similar to what we've been talking about during this section. What brought the patient here? My first question, no matter what, when I'm seeing a patient, is what brings you in today? Because that may be variable, and the answers you get can be helpful. Sometimes I have patients come in and they'll tell me, oh, well, your partner sent me over to see you. That's a very big difference than I'm miserable, I can't sleep at night, I'm having difficulty walking. And most patients will just point to their neck or their back and say, back pain, neck pain, and then you have to flesh it out. It's not easy. This takes time, but you really have to develop this empathy and understanding. Try to figure out what they're coming in with in concert with all of the observational findings that you have, and try to see what they're doing to see you. Why did they come in and go through things? And unfortunately, there's going to be some times where there are mitigating factors. Some patients hate their job, and some patients have some problems. And I'm not going to say that there are many patients that are purely malingering, but there's a factor there. You have to be cognizant of that as well. I like to give the benefit of the doubt to these patients, especially if they're in pain, but you have to understand that there can be mitigating factors. Mood disorders and other factors of that nature really can change what the pain perception is and how you're going to be able to successfully treat it. And all of that fits into a stated note that Dr. Keith Michael, one of my other mentors at Emory, calls spinechiatry. You have to understand that there's pain involved often, but that this pain can change how they perceive their day-to-day basis and can develop depression, anxiety, and things of that nature, particularly if they've been treated with other narcotic medications or other different ways of treating the pain that have brought them here. They may have a long journey prior to getting to your office, and you have to understand all of those treatments they've been through and how frustrating they have or have not been, and how you can best address them. And again, when you're explaining this problem, so not only when you're looking at what brought them in and why they are here, now you have to discuss with them that problem. And I think you have to understand that your story and what you're telling a patient and the pathology is largely within about 3 or 4 common veins. And so you have a bit of a spiel, a discussion that you're normally saying to patients, particularly operative patients, and you really have to customize it. And one of the things is when I'm going through pictures with a patient, MRIs, X-rays, things of that nature, I try to encourage them to interrupt me and ask questions. I find that a patient that just quietly sits there and nods their head probably is not really understanding a majority of what I'm trying to get through to them. And I think it's tough because a lot of times they're in pain. They want a simple solution for a complex problem. And when you're trying to break down all of these specific details about facet arthropathy, foraminal stenosis, central stenosis, loss of disc height, kyphosis, loss of normal lumbar lordosis, things of that nature, they're not really, that took us years to train to understand, and you're trying to explain it in 5 minutes. And so I think it's important to customize things to that patient and understand their background. And at the end, ask questions, have the patient ask questions. If they don't ask any questions, I'm also concerned because I don't know how well I have or have not engaged the patient. So it's not even as much you trying to make sure the patient understands. It's about you learning whether or not the patient is engaged in this process and wants to get better or wants to pursue further information about the problem. And then you get into the treatment plan. So you've explained things and you've gone through a laundry list of their problems. And then you have to discuss how you're going to fix it. And again, the patient doesn't know to ask about medial facetectomies and how far in the foramen you can get to take care of this foraminal disc, whether or not you have to do a complete facetectomy to get down into the space to restore disc height and foraminal height, things of that nature. They're not thinking about that. They just want the pain to go away. So I often find that if we're going into the treatment process, have a model, have a picture, give them something to look over. That's going to help explain things much more. And I often find that there's a moment with most patients as they're trying to figure out what you're telling them, that things start to click a little bit. And I think it's not as much going through a bunch of different things, but trying to have a very clear picture. And you're going to have to do this over and over and over again sometimes. And then after you're discussing the treatment plan, they really want to care about more of the practical things. It's funny, you'll do an outstanding decompression thing. This is something Adam and I talk about a lot. You'll do this great decompression and you'll have done all of this bony work and have instrumented things well, but really all they care about is, how's my incision look? And what do the x-rays look like? Is that what the x-ray is supposed to look like? And it's it's the little things, these little details that are the ones that are probably the ones that hang up the patient the most. And it helps you understand what their postoperative follow-up and their care is going to be, which is so critical to the overall outcome. And so I think about these a lot, and I actually have a packet. It's 5 pages long that goes through frequently asked questions that answer all of the questions at the bottom here. How long am I in the hospital is a critical one, and understanding things, getting back to those very basic human activities after the procedure. Those are extremely important to the patient and honestly should be important to you as well. So another key point in treating the problem is understanding that I believe if you can do just a decompression, understanding what that means and the indications for that. So foraminal stenosis is something that you really have to understand whether or not you can safely get to it and decompress that adequately, because one of the things you absolutely want to avoid is trying to do a half measure in terms of a lumbar decompression and not fully ridding the patient of that radicular symptom that they are having. And I think the facet is really the lighthouse to this. And so the illustration here is that if the facet, the inferior and superior articular processes of the facet joint are oriented in a more coronal plane, I feel much more comfortable that I can get out further into the foramen. I'm taking less of the medial facet, which minimizes the instability and can figure things out in terms of getting an adequate decompression and avoid the need for fusion. And conversely, if it's a sagittally aligned facet, I really have to think, is this mostly a central or lateral recess stenosis that I can get to? Am I going to be able to get across to the foramen? Can I do a hemilaminotomy? Can I do less, or am I going to have to take off more of the lamina contralaterally and get out into that foramen? Can I get there safely without destabilizing things? I really think a CT scan really can help define this much better than the MRI. The MRI does help with the arthropathy and fluid within a facet joint to suggest whether or not there is some dynamic instability. But I think the CT ultimately is going to really help you understand what bony decompression you can and cannot do. And I think of it like Jenga. What can you take away, but keep the tower intact? And understanding that is critical in terms of the long-term outcome. And then when it comes to fusions and things of that nature, you have to understand what's their main problem and how are you treating it. If you're fusing a patient, you can help with the back pain, but I think you have to really think about alignment in those aspects. So do they have a kyphotic lordotic problem, or is this more of a radicular problem in which the facet arthropathy, disc herniation, and ligamentum hypertrophy are basically coming around and really creating misery for that exiting and traversing nerve root? And in those cases, I really think that foraminal height is the key. And so you have to figure out and look at what their normal is at the adjacent levels and understand how you're going to get that back. And there are so many different ways, as you see on the right, to achieve that. There are inner bodies, you can go laterally, prone lateral, and all kinds of new techniques and less invasive ways of treating this. But at the end of the day, you have to understand that what you're doing is restoring anatomy, and understanding that you have to figure out the best way to do that, the safest way. And the worst thing you can do is a really well done fusion and create a flat back deformity. You didn't achieve a good sagittal balance and they are fused in kyphosis. So you could have them fused like gangbusters, but if you did it in the wrong or in a less than ideal position, the risk of adjacent segment disease and just overall ambulatory dysfunction long term is much higher in those instances. So I think to myself, if the chief complaint is coming down the leg, think about the nerve. If there's more of this back pain or positional discomfort and I'm fusing a patient, make sure my alignment can be optimized. Postoperative pain, when you're first in the hospital, you got to be multimodal. It's by far the most important thing. You got to throw everything you can at this. You have to understand that, especially in an open situation in which you're doing a very thorough decompression, those muscles are under stretch for multiple hours, and you've removed a good amount of muscle to get into that posterolateral gutter if you are fusing through that modality. And so these patients have these very large, very low frequency, but active muscles that are just firing in pain and creating spasms. It's like having a Charlie horse in your back while you're seated, walking, standing, things of that nature. And it's a fairly consistent thing. So that's why the patient looks like they've gotten hit by a truck, especially the patients who have more muscle with which to work, whereas some of your elderly and less muscular strength or amount of muscle actually bounce back a little bit quicker. And then I think you need to have these interventions spaced out, especially the scheduled ones. And then that way the PRN can kind of come in. And I think the fact that a patient is receiving different modalities at different times may also have them have a perception that their pain will be under better control by throwing more things at them in a different interval. And at home, when they come back, if they have some residual radicular symptoms, a Medrol dose pack can be helpful at times. I oftentimes will consider them in the first 2 to 6 weeks postoperatively. And then can you use anti-inflammatories with a fusion? The jury's still out, I would say. I think of it as something that can be used in short pulses, but would not keep it on for a long-term period of time. And I think you have to look at the relative risk of pseudoarthrosis for a patient. Are they a smoker? Do they have diabetes or any other medical comorbidities or things of that nature, for which that plus the anti-inflammatories puts it at higher risk. When can you get rid of the pain? I think perhaps this bullet point is one of the most important things. You have to kind of almost talk them out of the surgery before they go into the surgery, if you will, from an elective standpoint. I try to tell them that this takes time. And I think to myself, 3 months is about the minimum before I think you should intervene, assuming everything else is reasonable and there hasn't been a significant change in their motor or radicular functions. 3 months is the minimum for a decompression, and fusion, it can take much longer. The actual bony fusion takes 9 to 12 months, but their evaluation of things will have to follow that. And you have to hammer home that concept over and over and over again to the patient. And that should be under more than one time frame. I think if it's a visit in person followed by a phone call, that's reasonable. But I think it's very important that they understand the long-term processes in this recovery and where they're getting to and how long that road to recovery can be. It's really important for them to understand that things like numbness and weakness can take longer to recover. And then I think one of the most helpful things I've been taught is that the 3 most likely complications for your patient should be the ones that are cited with each surgery. So every patient that I see, I have a patient who's a smoker with diabetes. I say, there could be wound problems afterwards. And I kind of repeat that along with other things like pseudoarthrosis and issues with some of their pain control and risk of adjacent segment disease. So understand what are your most likely problems that you're going to see down the road and tell the patient about them ahead of time. Patients oftentimes, if they are told what can and cannot happen and are not blindsided or surprised, it makes a huge difference in their perception of what's going on. The biggest thing they fear is if there is something that is going on that is unexpected and concerning. And myself, as a deathly afraid of aviation person, will irrationally get terrified when part of the plane shakes back and forth. And, that's a very common thing. But if I had seen the pilot walking down the aisle and talking to the stewardess and I didn't know he was going to do that, I'm going to get a little white knuckle situation going on. So you have to understand that the patient's in the same boat. They're sitting in a bed, they're in pain after a surgery, and then you're telling them they have to lie flat on their back for 24 to 48 hours. It's good to let them know that that may be something that was going to happen. And the fact that you tell them beforehand makes a huge difference in how they perceive that problem. And as the patient goes home, part of my packet that I give to them is things that are worth calling about and the parameters, giving them a rubric to understand what problems are normal and what problems are abnormal. Let the patient's care team, if that's a spouse, a daughter, son, family member, friend, whoever's going to check on the patient for you, if it's a home nurse, you have to empower them, give them opportunities to intervene on their own to help limit how much they are calling and waiting for you to interact, because there are many, many things that are not severe problems that still require being addressed. And if you empower someone that's there on a daily basis with the patient, I think your satisfaction and the patient's satisfaction in terms of the recovery process can be improved, and have a very good line of communication. So just make sure that you have a clinical team, and however you as a provider provide your communication, make sure that it is succinct and that is well streamlined, and that there's not a kink in the system. If someone answers a phone call that at a time when you're unavailable to talk with the patient and is telling them something that you would not say or agree with, that's a problem. So make sure that the line of communication, those that talk to the patient, have an understanding of what you want that patient to know and under what parameters and guidelines. So we're almost through this, but just wanted to reiterate some key concepts here. The physical exam should be exhausting for both the patient and the provider. Observing and learning so much within that first 30 seconds of seeing the patient will help understand what the patient's going through, learn why they are here, and that can be extremely variable and rather difficult to truly figure out when you're discussing the problem and trying to figure out the treatment. Undersell and overdeliver, that is critical to having them have a positive outcome and perceive that outcome to be positive. And clarity and repetition are going to be critical for your communication. So just real quick, I'd like to talk about one of my patients that I took care of in the fall. It's a 53-year-old gentleman. His chief complaint is fourth and fifth toe numbness. It's been going on for 3 weeks. He hates it. He's miserable. We give him, I send him over for PT. He gets an epidural. Nothing's helping. And we start Lyrica at the second follow-up. And the pain, actually, the discomfort, which was associated with the numbness, is a little bit better. He's unhappy. Here are the x-rays, just going through his pictures. There's a little bit of degenerative disc disease at 5'1", little hypolordosis, but largely not significant deformity or concerns. So we do a month follow-up, another epidural. The epidural knocks out the pain. The patient's not happy. He's still upset. Foot does not feel normal, is what he keeps telling me. He's a soccer active guy. He's fit, in good shape. We get the MRI. We're about 6 to 8 weeks in. MRI study shows a disc herniation. It's in and around the foraminal recess. I think it's something that we can tackle, but I really talk to the patient and say, hey, you know, we've gone through some of the process. We've gotten your pain better. I think that long-term, because of the epidural helping with your pain, we can get that to be a long-term benefit. And I'm not sure about the numbness. We hopefully can get rid of that, but I really have to lay some crepe there. And so we do a 5-1 microdiscectomy and foraminal decompression on that side. 2-week post-op, the sensation's back in the toes. He's feeling a lot better, and you get this big smile. And he said that at first that step started to feel like the foot again. And he could not wait to kick a soccer ball with his son at Thanksgiving, who was coming back from college and is a collegiate soccer player. So you learn so much about how important something as small as fourth and fifth toe sensation would be to this gentleman, and how you can improve something that small and focus on all these little details that I missed in the first 8 to 10 weeks, and something perhaps that the patient didn't want to even share with me. But you learn so much during this process when you're taking care of people. And so when people ask, does spine surgery work? I think it does, and I'm willing to dedicate my career to figuring it out and helping people like that gentleman we just discussed. Thank you for your time and undivided attention, and I appreciate the opportunity to chat with you all. This is my email. And then again, we're part of the Comprehensive Spine Center here at Redeemer Health. And I do not know if this will come up, but yes, so here is our website and here's our team that is taking care of patients over at Redeemer Hospital. Thank you again.
Dr. McKenzie, thank you very much for such a great talk. We have several questions for you. If multi-specialty neuro-ortho groups make sense, why there are so few of them around? And do you think this is a model of the future?
Absolutely. We discussed this back in November during the GNI conference, and I think it's the future. And it's something, Vez and I were talking about. And part of the reason I really wanted to join this team with Redeemer Health and the Global Neurosciences Institute was to change this paradigm, because one of the things that Adam and I are doing over at Redeemer Health is working together. And the spine actually naturally can be improved with two physicians working on the same pathology, as there's two sides oftentimes to a decompression infusion. So, I think it's something that is building, and I think we're at the forefront of this with GNI.
Because we have a lot of providers here who considering referring their patients for spine problems. Can you explain a little bit about the whole Redeemer Spine Center? What is it different? What patient can expect from get-go that could be different, and why the provider should be sending their patients to this center?
I think what we try to do is we provide, either if you see myself or my physician assistant, Tyler Sullivan, what you're going to get is one viewpoint, but then we have opportunities where we upload imaging and we talk amongst other providers. So as a patient that's coming over to the Comprehensive Spine Center, you're going to get multiple viewpoints on your problem, regardless of what's going on. And even if you decide to have treatment elsewhere, you'll at least get a little bit more information. And we actually have a weekly Tuesday morning conference over Zoom in which we're discussing indications for surgery and learning how to get better, and asking multiple people from multiple backgrounds, what would you do about X? How would you take care of Mr. Jones? And that makes a huge difference in the overall care when you bring more people together. And I think that gives you a consensus and provides confidence for the provider and can help the patient get better in a more unique and less dogmatic way.
We have some more questions. Can you explain a little bit more of the weight-bearing X-ray? What is that?
So when you're ordering X-rays for the lumbar or cervical spine, the patient should be standing. And that can be hard. And I understand you have to talk to your X-ray tech. There are some patients that are walker dependent or patients that need assistance when they're standing. But basically a weight-bearing X-ray means they're standing. So if they have a lumbar spine problem, I have them stand as best as they can. And then flexion and extension, you have them flex to the best of their ability and extend to the best of their ability, obviously being mindful of any balance issues in the elderly. So it's kind of a do the best you can, but they have to be standing for it to be weight bearing.
Now, for the providers who are not orthopedic or neuro people, what if somebody is evaluating a patient with a back pain or neck pain, when do you choose X-ray versus dynamic X-ray versus CAT scan versus MRI? I mean, what are the indications for all these studies?
Yeah, so it takes time. And so my thoughts are that within the first 6 weeks, I typically say that X-rays are not indicated if it is axial neck or low back pain. So if it's just that with no radicular symptoms, I think it is very reasonable to treat that without any radiographic imaging and see how they're doing. At about 6 weeks, if they have not improved in the axial neck or back pain with some modality, physical therapy or a pharmaceutical intervention, that's when you can get that screening X-ray. And then subsequently, based on those X-ray results and another physical examination, you can decide whether or not an MRI is indicated. I would say that an MRI is indicated when there is radicular symptoms, numbness, or weakness of the extremities for which you're assessing whether or not there's stenosis.
Okay. So the surgery for spinal stenosis, yes, no, specific scenarios?
So it's I think it's one of the hardest questions There's not a simple answer to that. It depends on where the stenosis is. So is it central, lateral, recess, or foraminal, and whether or not that stenosis matches where their symptom complaint is. So, if they have neurogenic claudication with severe central stenosis, I think that's a very well indicated procedure if it can safely be done, where you can do a partial or full laminectomy. If they have foraminal stenosis in an area where it has gotten better with an epidural injection and you feel comfortable that you can get to it, that can be a reasonable way to treat that type of stenosis. So it depends on the type, and it depends on what you've done preoperatively to have an idea of what your postoperative success will be for that.
There's another question about the indications for surgery, and that's in case of scoliosis. When the surgery is indicated?
There are kind of two flavors of scoliosis in my mind. There's the pediatric scoliosis, for which I really haven't trained, and there are a lot of differing indications for that. But I'll speak to degenerative scoliosis. So a patient with degenerative scoliosis, they have to understand what they're going through has a significant change in their overall function. So most degenerative scoliosis patients may often need something like a T10 to pelvis or a longer fusion construct. So I explain to those patients, they need to understand that the indications from my standpoint would be debilitating mobility in which they're unable to ambulate the way that they want to, and that subsequently after that type of procedure, our goal is to have them standing correctly and walking better, and understanding that that can take a year plus before their full recovery. So I really, of all the pessimistic things, T10 to the pelvis or some sort of deformity correction, those are where we have to engage that process.
Post-op pain management, you mentioned Tylenol, IV or PO?
Both. I think you can probably start IV in the first 24 hours is what I'll typically do. And then I will switch them to oral around the clock. And that's whether or not your hospital has that available. I do understand that there is a larger cost burden on the IV Tylenol. I do think it's a little bit better in the immediate post-op period. The other question I often get is Decadron and if and when to use that post-operatively. I think if they have some sharp radicular symptoms following the procedure that are irritating, it's worth considering doing a short dose of Decadron in the immediate post-operative period, particularly if it's limiting their physical therapy.
Somebody has discogenic spinal stenosis in the neck, and it doesn't compress the spinal cord, but they sustain a whiplash injury and has some spinal cord injury. Is that an indication for surgery?
Depends on their physical examination thereafter. So it's a really good question. You have to understand, what is the subsequent amount of stenosis, and that's where the dynamic films are helpful. So you can see whether or not there is instability within the spine. Is there a subtle injury or fracture that's causing instability? That's more of an indication for a decompression infusion. And then you also have to think, is this like a central cord type situation where they're having difficulty using their hands, and whether or not that decompression has a long-term benefit, or is this just simply a one-off where they've developed an injury, there is some myomalacia, but there's really no stenosis? There, I'd be very cautious. I would try to follow them a little bit more clinically before pulling the trigger.
Right. And if somebody has a chronic cervical myelopathy, because of, again, discogenic cause, whatever, how urgent what's the urgency of the surgery? If you're evaluating in the office, is it like needs to be done tomorrow, or it can wait a month, so.
Yeah, great question. I think it depends on where they are functionally. So when I think of myelopathy, it's a stepwise deterioration. How many steps have we gone down? How long is chronic? 3 months, 6 months, 1 year. Those factors make a big difference. I say the sooner the better is often the case, but you have to make sure you can safely take care of the problem. So what I mean by that is a lot of chronic cervical myelopathy patients are often either infirmed or significant functionally limited. And so you don't want to immediately go for the decompression because of the degree of stenosis if it's gone on for greater than 3 months, unless there's been a acute sharp decline very quickly within that time frame. So I will tell them they need surgery. We will get them evaluated. And if things change significantly, if another step of deterioration has occurred, we'll pull the trigger sooner rather than later.
Dr. McKenzie, thank you again for such a great talk. I'm getting some reviews, and the reviews are great. Everybody have a good rest of the day.